The challenge for us as dentists is unique in the fact that we're being asked, in many cases, to repair the dentition and the foundation of that dentition, the bone and soft tissue. And the challenge for us is quite significant depending upon the severity of the anatomy or the patient's presenting anatomy. As John Coyce often talks about, the limitations of treatment may in fact have more to do with the patient's presenting anatomy than it does the techniques and skill of the practitioner. When I remove the bone and soft tissue, we're really left with the things that many of us deal with on a daily basis: how to reconstruct the form, function, and occlusion of the actual teeth themselves. And if we remove the teeth, what I spend most of my time doing is actually the foundation work. My attempt as an orthodontist and a periodontist and a surgeon who does implants is how do I reconstruct the gingiva in order to hand the case off to my restorative colleagues in my laboratory to give them the best chance for an aesthetic and long-lasting restoration. In essence, we may think of all of the gum and all of the bone, and you may think of all of the ceramic and all of the occlusal surfaces. Today, I'm going to spend most of my time talking about this area here, what I call the challenge zone. The area probably that amounts to about 3 to 4 millimeters, from 2 to 3 millimeters subgingivally to the first millimeter of emergence profile of your future restoration. It is in this area that most of us make our mistakes, and it is in this area that we need those little pearls to understand what exactly is happening here and how we can establish the proper aesthetics in this very critical zone, the gingival margin and the papilla support. So we're going to end up talking a little bit about the pink aesthetics as well as the white aesthetics of your restoration. And in a case like this, where we have a number of veneers and crowns and implants, not being able to detect which one is which is our goal. And of course, if we're able to put this together and build the ridges and build the contours, we invariably end up with the pink and white aesthetics also highlighting and supporting the lips and the lower facial profile, which is so very important to overall facial aesthetics. And we like to talk about the interface, or the development of this interface. And I'm going to talk a little bit about the fact early on in the lecture that a single implant has a different issue than, of course, if we're losing 2 teeth, especially if they're adjacent to one another. And this changes dramatically if, in fact, we're dealing with a fully edentulous patient. Where does that interface happen? How do we handle and manage it? And what are the biological ramifications of these different anatomical deficiencies? If you take a look at a patient with adjacent missing teeth, this is a patient that came to me as a third referral for second opinion. He was getting married in 5 or 6 months. He had been through 2 different surgeons and 3 different procedures. A lateral and central were to be replaced, and he was at wit's end. When I look at this case, the number one reason for failure, in my estimation, is really a diagnostic error. And the diagnostic error is not about osseointegration. In many cases, you will get osseointegration because we have a high rate of success with osseointegration. But is there a formula that I can give you all, that you can take back to your office and say, you know, if I follow this formula, the variables, if we remember arithmetic and basic math in school, you remember there were variables. Is there such a formula where x plus y plus z would equal success? And I worked very hard over the last few years of trying to develop these ideas with my partners and how to avoid, not the fact that you're going to do it 100% of the time, but how do we minimize error? How do we minimize these types of problems? If you look in the literature, many times I think it's important to try to base your ideas on supportive literature and research. 2 of the articles you see here are going to be supported some of the things I'm going to be discussing with you today. In 2007, Ronald Young from Switzerland talked about the importance of gingival thickness when replacing teeth, especially when talking about color change and tissue stability around implant restorations, and the importance of tissue thickness on what type of abutment you utilize. Dr. Grunder, in 2005, and I'm sure that Stefano on Monday talked a little bit about this with you, the importance, and this is his article with Dr. Grinder, the importance of the thickness of the labial bone in front of our implants to maintain that bone, even though we end up with some resorption, that we don't lose this very, very important area of bone. It stabilizes the color, it stabilizes the tissue margin. In 1998, and then again in 2001 and 2007, our group in Atlanta started talking about the importance of interproximal height of bone, not just around teeth, as Dr. Tarnow did in 1992, but actually around every possible fixed restorative option, whether it be implants, Pontics, or teeth. We actually took Dennis's information and we tried to take it to every possible restorative situation. These are the three areas. These are the variables, the X, the Y, and the Z. If we have those things and understand their ramifications, we become better diagnosticians and treatment planners. In a case like this, where I've reconstructed the ridge with bone and tissue, I have thick tissue, I have good bone support, I look at the labial plate through CT scan, bone sounding, I have my labial plate present. The interproximal bone on the adjacent natural teeth have not been damaged by trauma or periodontal disease. This is a type 1 case. Type 1 case is an ideal case. It's a case that we should be able to manage quite readily. What are the critical measurements in tooth replacement clinically? How do we do this? A little bit of anesthesia, unless it's somebody you don't like. Periodontal probe, digital reading, about 3 millimeters up from the gingival margin. You poke through that tissue, take a look at how thick it is. According to Dr. Young's work, he says you really want about 2 millimeters of tissue, especially if you're going to be working with implants. You don't need that around teeth unless you're dealing with a darkened root. You probe for the buccal ledge of bone on the labial plate. You want to know where the location of that bone is. Is there a dehiscence, fenestration? Today we have CT scan images. We want to know where that bone is. We also, if you place your probe through the tissue, according to some of the work done by Kahn and Coyce, if you start to see these laser marks through the tissue, it's usually a sign that the tissue is going to be a little thin for what we want to do. And then, of course, probing the interproximal bone around the teeth that you're going to be working on, just facial to the interproximal contact. So it doesn't matter where the bone is on the palate. It doesn't even matter where it is directly underneath the contact, but just facial along the transitional line angle. You want to know where that interproximal bone is. On CT scans today, by the way, a little trick. If you put a cotton roll underneath the lip, when you take your CT, you will not only see the bone, as you see here around the implant that we place, but you can actually measure the soft tissue thickness on a CT scan. So a little trick when you're trying to understand why you may have to do soft tissue graft, cotton roll in the vestibule will do that for you. I like to always say that anything you see, certainly for me and many of the speakers, even when you say, wow, that's a great idea, has been stolen from the tombs of those that predated us. It comes from, many times, ideas that came a long time ago. And many of the things I'm about to speak to you about are not new. They've just been modified to be utilized in a different manner. Back in 1993, I published an article with my brother that talked about a systematic approach to the management of extraction site defects as it related to implants. I know it dates me a little bit, but 1993 we published it. You can see from the actual very, very poor Harvard graphics that were utilized how old this article is. We basically simplified it. We said you have three different types of defects. You have a type 1 case that's basically a good situation, no bone loss or tissue loss, a type 2 with moderate bone and tissue loss, and a type 3 with severe bone and tissue loss. And what we've done over the last 16 or 17 years is basically taken that information and have transferred it over to the implant regimen, where we look at a case like this, where we'd say this is a type 1 ridge, good bone thickness, buccolingually, vertically. We then move along. This would be green, meaning go ahead, do this case. A type 2 defect, which could be with teeth or edentulous areas. In a case like this with severe recession, bone that's been lost on the facial aspect. A labial defect could be a concavity from an extraction site. But these are defects that are basically horizontal in nature. And a type 2 defect to me today, with what we have to reconstruct, is only a yellow light. And I don't know how many of you do with yellow lights. I'm the type of person who kind of steps on the gas to get through the yellow light. So in a type 2 case, I think you can get a good result. It's not something you pause, you figure out which way you want to graft that area, but we can get a very, very predictable result with a type 2 case, whether it be loss of the buccal plate entirely or not. And one of the reasons, and I'm about to show you a type 3 case, the reason that this is as substantial loss of bone as this is, a type 2 case for me, is because the interproximal bone on the adjacent teeth have not been lost, as opposed to this case. Type 3 case, where we've lost a substantial amount of interproximal bone. This could be readily due to periodontal disease, infection, or of course trauma. Any type of defect, whether they have teeth or not, that involves the interproximal loss of bone, a vertical component gets a red color from my group in my office. We really spend time to discuss the options with the patients. Because this can be, and this just died. Okay. Because this can be something that's quite substantial. I'm going to go back a couple of slides. And if you look at this defect right here, you'll see that this is without teeth, a vertical component to this ridge defect, and again, that we really have to spend time in how we're going to go about treating this case. So type 1 case, this is a slam dunk. Type 2 case, you may take a pause, come up with the best solution, but it has a high predictability. In a type 3 case, low predictability. You're going to have to stage treatment, and you have to go ahead and give your patients multiple options and understand that there's limitations in what we can actually do for them. Over the last couple of years, my group and some colleagues in Japan published a series of papers that highlighted this importance of diagnostic regimen. And if you see a case such as this one with an implant, a submerged root, another implant, and a concept I'm going to be speaking about with you in just a moment, what we basically did is introduced this chart. And this chart is something that I use each and every day in my practice. As I said to you before, if anybody wants this information, it is available, the articles for PDFs, downloads from dentalxp.com. This chart is available as well, so if you don't get a chance to write it down, certainly you have access to it. 6 different fixed restorative options, and each one of them have different limitations, proximity limitations or vertical gingival dimensional differences in how much tissue we can expect above the available interproximal bone. And each one of these situations is entirely different, whether they're Pontics, implants, or natural teeth. And today, just in a nutshell, we have really 3 substantial measurements that you should recognize. In an article published with Dr. Tarnow, our group, and his and several other facilities, the measurement we can expect between 2 adjacent implants is only 3.4 millimeters. Some people are starting to look at that and saying that's going to change over the next several years, but that's pretty much what you can expect today. An implant next to a tooth, 4.5 millimeters above the bone, and an implant next to a Pontic, as much as 5.5 millimeters, and the range in this one was actually quite large. We were, in some cases, as much as 8.5 millimeters of tissue above the bone when we segregated implants with a Pontic. So again, in an effort to give you some ideas on how we look at things, I wanted to first highlight to you what actually occurs with some of the things that we're doing quite readily today. How do we manage the potential extraction site? This patient presented, fractured central incisor, had been restored a few years ago with multiple single unit crowns. Obviously this fracture is hopeless, and one of the things that we start to do is learn more about extraction sites. What occurs when we actually lose the tooth? Well, when we lose the tooth, depending upon the particular patient, we're usually left with a very thin labial plate of bone. And I say in the high majority of cases, this is the case. Somewhere between 0.5 or 2 millimeters is what you would expect. Now, what happens to that bone invariably is going to affect us, especially in the aesthetic zone. And we know more about this today than ever before. Let me take you through a case that I treated. This is a patient with high aesthetic expectations. She's in the process of planning to have a child. She wants to get this done. She just got married, and now that she has a husband to pay for it, she wants to make sure it comes out really well. So I look at this case and I say, you know what, this patient has very highly scalloped gingiva. This is what we would call highly scalloped. I think we'd all agree. She also has inflammation on the facial, and when you look at it here, you'll see how thin that tissue is, and it's inflamed. So I want to make certain that I end up with the best result I can, because she happens to be married to a friend of mine. And since he's footing the bill, I figured I'd use as many techniques as I can. He can afford it. So I look at the case and I said, well, what do we know today? What do we know today, and what do we think we know about the management of this type of area? I mean, it's a pretty simple case. We all run into this, and probably each and every day. Extractions are a big thing. We are faced with teeth that fail. Well, what do we know today? We know a lot more today than we ever did about extraction sites, predominantly because of implants. Nevins in 2006 did a real simple study. He took CT scans of teeth just like the one you saw after extraction. And this is what he found, pretty much what I just showed you on diagram. And he started to focus on that labial plate of bone. I also like periotomes. There are a lot of different ways to extract teeth. In terms of single-rooted teeth, unlike the previous speaker, single-rooted teeth are a lot easier than multiple-rooted teeth. We can go down the periodontal ligament space, as was mentioned, with a periotome. I like the idea of using a mallet sometimes to get this periotome down and wedge it in place. I never use any instrument on the facial aspect of the tooth to be extracted in the aesthetic zone. Always mesial distally and palpably. A lot of different techniques. You can use a piezo-surgical device, which I'll talk about later, or there's some pulley systems and vertical extractors such as Easy Extract from A-Titan, or you can use the Bendix system from Brasseler or Salvin. So what do we know about this bone after we extract it? What we do know about this bone is part of its vascularity comes from the periodontal ligament. So when you remove the tooth, it's losing almost half of its vascularity. The rest comes from the periosteum. What Dr. Nevins showed is when you did nothing in this area, at 61 days, when the same patient came back from the same CT, he said he lost a substantial amount of the labial plate. So we certainly know we need to do something. Today, we're going to use socket grafting. Some of us, I mean, you've seen me many times talk about the utilization of growth factors, bioactive modifiers, like PRGF. In this case, I want to make it quite simple. I utilize recombinant PRGF, plasma-rich growth factor. This is GEM21 from BioOs. I use this with some BioOs and the GEM21 saturated into this, and I packed it very loosely. You don't want to densely pack a socket. You want to loosely pack it so you allow for angiogenesis. If you take a look at Dr. Nevins' study, which was the fate of the buccal wall of extraction sites of teeth with prominent roots, these are one of the things that he found. Very thin labial plate, and that look at the amount of resorption that can take place. And what he concluded was there was a significant number of buccal plate casualties, even when carefully selected clinicians, these were some of the top clinicians he can find, extracted teeth with prominent roots. I'm sure many of you would think that you're conscientious and you do a good job, like the previous presenter showed you, how to extract teeth. This resulted in a deformed, localized edentulous ridge for the control group compared to those extraction sites that received BioOs. What's interesting here, and I know you can't read it, so I'll read it for you, some wounds healed correctly with no treatment, but were unable to be identified before extraction in this randomized study. What was also interesting is that even when he was able to preserve the roots with BioOs, he found that he lost up to 20% of that labial bone and tissue at the crest. So I wanted to make sure, this is a friend's wife, I not only put the tissue in here and used bioactive modifier, I said, what the heck, I'm going to place tissue on the labial the same day. I'm going to use a tunneling approach. I'm going to go and do a sharp dissection, leave the periosteum, take autogenous tissue from the palate, and I'm going to place it into the facial aspect and over the bone so that I really stabilize that wound and augment both the tissue and the socket. And I used the marionette suture, an anchor suture, and I pulled this tissue up into this area. I packed it in with a tissue packer from Brasseler, and then I knotted this off, and here's, you can see the wound on the palate. I sutured it again, tunneling on the lingual aspect to completely cover this socket seal procedure. This is something that Kobe Landsberg, David Garber spoke about in the 80s and 90s. And really, I was quite pleased, and I said, boy, I think I did everything that I needed to do to preserve the contents and the structure of this very, very important area of the mouth. This was 4 months healing when the patient comes back. Let's take a look and isolate. Even in an area where we've done grafting, look at what was maintained. The vertical of the area has been maintained not because of what I did, not because of the graft or the tissue or the bone or the PRGF, but because the adjacent natural teeth were still healthy and the interdental bone on either side supported the vertical. Just the tent pole was there to support the tissue. But buccolingually, even though I did all that grafting, I still lost some volume, as much as 20%, maybe 25% of the buccolingual thickness of the ridge. The reason that this bone is here is because the interproximal bone sounding that I spoke about earlier showed me that the bone was healthy on the adjacent teeth. So that supports the vertical in single tooth extraction sites. If we take a look at this, and we realize what Dr. Nevin showed us, very interesting thing. In a case where he grafted BioOs, what Dr. Nevin said is that when you grafted BioOs, came back 180 days later, that you maintained the labial plate. But his conclusions were that sockets treated with BioOs demonstrated a loss of less than 20% of the buccal plate. So less than 20% does not mean 100%, and what you actually are lost is that area here, not up here where it's not seen, but actually the area of the zone that I identified earlier for you, that gingival restorative interface. With BioOs, a low turnover product, something that doesn't resorb very quickly like autogenous or allograft bone, this bone is going to be lost. So even going ahead and doing everything that we did, according to the literature, what Dr. Lindy said in 2007 in a journal of clinical perio, he said that this bone here is something he called bundle bone. It's bone that actually has its remnants from a follicular stage, and he said that this bone is only supported vascularly by the periodontal ligament. It's not by the periosteum. And when you remove the tooth, that this bone is lost by up to 1 millimeter. So we got some pretty big people telling us you're going to lose a little bit of bone tissue contour of your ridge. Nevins and Lindy telling us this little area that I just shared with you is not going to be regenerated, even with all the grafting that we do in the socket. We can't depend on it. Bone fill at 4 months. Let's take a look what it looks when I re-enter the area I want to share with you. What do you think it would look like? You remember that ridge deficiency that we saw? This is exactly, I'm sharing with you a clinical case that's almost identical to what you would see based upon the literature and the references I just shared with you. The bone down at the depth of the extraction site has been maintained. You can see it here. But look at the bone on the adjacent teeth. Look at the bone on the adjacent teeth. Right here, where we need it the most, this area, that bundle bone, that crest of bone, has somewhat resorbed. We have enough bone to place an implant. We can add a little bit more bone and come back and treat the case adequately. It's not an issue. I know that everybody in the room is probably saying, that's an easy one. Yeah, you can. There's room for an implant lingually, and you just add something here to reconstitute the ridge form. But we now understand what we get when we extract the tooth. Let's look at this case. I showed it to you earlier. Patient came in. She was from Florida. She had this case done a few years earlier. I placed an implant. We went ahead and said I secured the implant immediately at the time of extraction, and then did an immediate temporary to make her happy, non-loaded. And many of you do that today, and I'm sure you've seen Joseph Kahn's work on Loma Linda. We went ahead, relined it with a little temporary cap, picked it up with acrylic, and this is the day of surgery. The patient walked out. No sutures. It was actually the exact same crown that she walked in with. I hollowed it out and relined it, so it was even her permanent ceramic crown. By the way, for those of you who like to make money, never do this again. She went back to Florida, and about 4 or 5 years later, Finally, I had somebody call me up and said, this thing came out. I don't know what is inside it. What kind of cement did you use? I said, that's a temporary. That's acrylic. He says, it looks like ceramic. I said, well, it's complicated. Put the tooth in. She comes back in a few years later, says she just really forgot. It was feeling so good. And eventually she comes back, and what do we see? Well, in an effort to be simplifying our surgical interventions and the number of surgical interventions, of time, predictability, let's be super critical of the aesthetic predictability of doing such a thing. She looks nice, she's smiling, she doesn't really show it very well, and that's a good thing, because if I share with you what she looks like when she smiles, what did I maintain? The interproximal soft tissue is fine. But look at what happened here, and this is not even 24 months when she makes it back down to Atlanta. What have we lost here? The limitations. And this is not just one case. This is something that is in the literature. If you really start to look and you look at your cases 1 and 2 years later after the remodeling that takes place, we're going to lose a little bit of that tissue. We're going to have some darkening because of remodeling that occurs to the labial plate. And this is a complication, although minor, that in some cases is intolerable for the patient. Why does this happen? Well, look at the literature. In 2005, Arohu, in their work in Sweden, said ridge alterations following implant placement in the dog model. And what they concluded was placement of an implant into a fresh extraction site by itself prevented the remodeling, failed to prevent the remodeling that is expected to occur in the walls of the socket. So just because we place an implant this time does not stop the resorption that takes place. You need to graft. You need to add grafting material. So let's get on to some difficult cases. I think that we did a lot to kind of set up my presentation. We talked about type 2 and type 3 sites. Here's a type 2 site, and here's a type 3 site. Type 3 sites are vertical defects that take place, where we have vertical bone loss, either on an area where a tooth was lost or area where teeth are retained. Let's start to isolate what this is. And this patient, believe it or not, and this is a very interesting story, this patient was the national sales manager of an implant company that we didn't use. And he happened to have had an implant fail. Never saw him before, just at the meetings, and he ended up in Atlanta. So I said, but I don't use your implant. He says, I don't care what screw you use. I've already been screwed. And if you look at the case, he tells me the story. Tooth was removed, implant placed, immediately loaded. He ended up losing the implant, lost the crown. They grafted it with a xenograftic product, and he lost the tissue on the lateral incisor as well, and the recession became worse. So this is what we're looking at. You're looking at it, I'm looking at it. And now we have to come up with a diagnosis.